All right. Good evening, everybody. Welcome to the November session of the Virtual Tumor Board. My name is Bob Akivi. I'll be your host tonight from New York City from Memorial Sloan Kettering. Today was an exceptionally light, bright, and mild fall day in New York City, and I know everybody wanted to go watch the World Series. So we're going to finish on time. We have an exceptionally amazing panel tonight. Our case presenters are Dr. Daniel Rocky, Dr. Ashley Mays, and Dr. Alan Ho, and our expert discussants are Dr. Russell Smith and Dr. Lisa Orloff. Nobody needs any introduction. They're all very well known. All right, without further ado, we're going to start with our first case, Dr. Daniel Rocky.
All right, let me see if I can share my screen here. Can you all see that?
Yes.
Yeah.
Perfect. All right. Need to see how I can get all your pictures off of my screen so I can read it. There we go. So this was a 26-year-old female that I had seen with a history of Graves' disease, diagnosed at age 18. So she'd been dealing with that for several years. She had a 1-year history of neck swelling and, like a lot of folks, delayed evaluation due to the COVID pandemic. She had seen another surgeon and came to me for a second opinion. And she had no family history of really any relevant diseases, but namely no history of thyroid cancer. On physical examination, she had a easily palpable left thyroid nodule, which was about 3 centimeters. And she had massive left-sided adenopathy, multiple nodes greater than 5 centimeters throughout levels 2 through 4. And she also had a right level 4 lymph node, which was about 4 to 5 centimeters. All these nodes were mobile. And other than this, she had a very unremarkable physical examination. Both of her vocal cords are mobile on fiber optic exam.
Okay, let me stop you right here, Dan. Dr. Orloff, I mean, you're an ultrasound guru, so forget that part. Patient comes to you with just obvious upfront lymphadenopathy. Do you just go to the axial imaging CT scan, or do you still say no? I'll just do ultrasound. You're muted, by the way.
So sorry. Nope. I consider ultrasound a part of my evaluation, my initial evaluation. So I can glean a lot of information and it can guide ordering of cross-sectional imaging, whether it would be a CT scan or an MRI, CT of the neck alone, CT of the neck and mediastinum, PET CT if it were something that appeared to be something beyond your typical thyroid cancer. So yeah, I think ultrasound still provides initial information on the disease at hand and on what further studies to order.
Dr. Smith, what are your thoughts on getting axial imaging in these cases?
So I agree with Lisa that ultrasound gives us a tremendous amount of information, and in the vast majority of patients, all the information we need. If the ultrasound suggests that there may be very extensive extrathyroidal extension of the primary tumor, and I'm worried about tracheal or laryngeal invasion, then that would prompt me to think about other imaging. If the disease extends low in the central neck, and I don't feel like I see the inferior extent of it going into the superior mediastinum, then that would prompt me to get more imaging with a cross-sectional imaging study.
Okay.
But if everything here looks like I can see it well with the ultrasound, I would be comfortable with ultrasound alone on this patient.
All right. Okay, Dan, tell us what you decided to do.
All right. Yeah, I do a lot of ultrasound in my clinic as well, like Lisa and Russell, but she had, I don't unfortunately have the images for her, but she had a left 3 centimeter thyroid nodule that was very suspicious, hypoechoic, solid, ill-defined borders with microcalcification. And not surprisingly, she had pretty massive cystic adenopathy on the left side in levels 3 and 4, and then suspicious nodes in level 2 also. And then similar concerning nodes on the right side. She had central neck disease, on the ultrasound as well, although it was a little bit difficult to see.
Okay. Did you have an did she come with an FNA to you, or you didn't have any biopsies?
She came with an FNA, yeah, which was papillary thyroid carcinoma.
Okay, so Dr. Smith, patient come to you with the FNA already. What's your routine? Do you repeat the FNA? Do you do the notes? Do you just do the thyroid? When do you say it's good? So when do you say, no, I need more information?
So I think with one biopsy, either of a node or of the primary tumor, you've established the diagnosis. It sounds like her imaging is very pathognomonic of having a larger primary tumor with fairly extensive nodal disease in the central neck and the bilateral lateral necks. And so I don't see a need for any additional biopsies, because it sounds like one biopsy confirms our suspicion, and the remainder of the imaging kind of tells the rest of her story.
Let me ask Dr. Allen in Cedars, do you guys repeat the biopsies? Do you
Sorry,
do you
don't know
trust those? What would you do?
In regard to your question about repeating the biopsy, generally speaking, the diagnosis of papillary thyroid cancer is fairly routine. I don't think you need a subspecialized pathologist to repeat the biopsy. So if they come with an outside FNA that says papillary thyroid carcinoma, unless there's something that doesn't add up, we tend to trust it. We'll request the slides if they come, but we wouldn't necessarily wait for them. I generally find that when we do request them, that our pathologist will agree with something as a commonplace vanilla diagnoses as papillary.
Okay. Do you send for genetic testing at this point for finding out any mutations, or it doesn't matter?
I'm more of a minimalist, Babak. I don't find that it will necessarily make or break our surgical planning. For me, it's more downstream if a patient has something that needs something along the lines of a targeted therapy.
Dr. Orloff, do you insist on having biopsies at the Stanford? Do you do both thyroid and the neck? Do you send for genetic testing?
So it's my institutional policy that slides are reviewed because of the not infrequent change in diagnosis. So especially for cancer, planned cancer treatment, we would review outside slides and not necessarily repeat them. And it's my understanding that that is more cost effective than repeating them, as well as less invasive. But if the metastatic disease was biopsied and positive, I wouldn't go back and biopsy the primary. But if the primary were biopsied and the nodes had not been biopsied, it may be appropriate to biopsy the nodes if there's not the obvious distinction between just prominent reactive lymphadenopathy and metastatic disease. Sometimes you just can't get to the metastatic nodes and you'll still operate on them, so it's not a hard and fast rule. And we don't usually do genetic testing up front if the diagnosis is papillary carcinoma. So,
perfect.
Yeah.
Thank you. All right, Dan.
Yeah, so we did get a CT with contrast. I tend to do this on people who have very bulky disease. It showed a lot of what we expected to see. It showed adenopathy in both bilateral lateral neck compartments and the central neck. And it also showed left-sided retropharyngeal adenopathy, which you can see in the axial and coronal planes here.
All right. So a question from the audience, I'll ask Dr. Orloff first and then Dr. Smith. The MRI versus CT, when do you do MRI, when do you do CT? And every time you want to do a CT, there's an endocrinologist in the audience that, oh my God, you're going to give contrast. So how do you answer that?
Yeah. Thanks, Babak. I just actually typed into the chat response because I think Tanya had asked the same thing, but I do try to minimize radiation exposure. So I think about MRI whenever possible in lieu of CT. But having said that, MRI is more prone to claustrophobia. It takes a lot longer to acquire the MRI images, and therefore the images are more susceptible to motion artifact. And sometimes it's just more expeditious to get the CT. It's slightly less expensive. And for the interface between the airway especially and the tumor, I think CT is better. generally speaking, soft tissue is, ideal with MRI, but I don't know about others, but when I get MRI images, there are all these sequences that the radiologist gets that I have no idea what to do with. They have all these weird names and they show images that I can't interpret anyway. So I think CT is very straightforward, and being conscious of minimizing radiation exposure, I think it's the most expeditious.
Dr. Smith.
Yeah, I think one of the misconceptions about MRI scan is that it gives you more soft tissue detail, but it only does that if you image a very finite area. So looking at the skull base, looking at the larynx, looking at a very specific organ, it gives you great imaging. If you try to do the entire neck from the skull base down into the mediastinum with MRI, it's really substandard imaging. It just doesn't give you the detail. And so I really try to avoid using MRI of the neck as a global exam, because I just think it doesn't give you the same information as a more focused MRI that's looking at specific pathology in specific areas. So I go ahead and get the CT scans, and if the endocrinologists are balking about, iodine load, you can check iodine levels in urine before you give them iodine therapy to help ease their anxiety. But for the most part, people clear their iodine from a CT scan pretty quickly, because you're getting it probably a few weeks pre-op. You're not going to treat them for 6 weeks post-op with iodine therapy. And so within 2 months, most people can clear their radioactive, clear their contrast iodine load before any concerns about treatment with radioactive iodine.
All right, we've got 6 more minutes to finish this case. Let's go. Dan?
All right. Yeah, so, oh God. There we go. So she had a total thyroidectomy, bilateral central and lateral neck dissection, and a left retropharyngeal neck dissection as well. The pathology was pretty much what you would expect in a 23-year-old, classic PTC with multiple satellite nodules of tumor in both sides of the thyroid, negative margins, and 23 of 65 nodes positive for PTC. No E&E, largest node was 3.5 centimeters, and there was that left retropharyngeal node.
Okay, some nitty-gritty questions. So, let me ask Dr. Mays, Ashley, if this patient comes to you, do you do this all in one session or you stage it?
No, good question. I've actually never staged it personally. I've always done the neck and the thyroid at the same time. I guess the question becomes the retropharyngeal. Maybe that's what you're getting at. But no, I've never staged these.
Okay. Do you do the thyroid first or do you do the neck first?
I personally do the thyroid first.
Okay. Dr. Smith, do you stage these or do you do it all in one day, just clean up the calendar? And
yeah, I wouldn't post this as the third case of the day. I'd probably make it the only case of the day. I would do this all in one setting. I would do the thyroid and the central neck first. I actually paralyzed my patients for their lateral neck dissections. And so from a practicality perspective, that eliminates the need for reversal of paralytics if you do the necks before the central neck from a nerve monitoring perspective.
Sure. Then do you do the retropharyngeal at the end after you do the lateral neck?
Yeah, I would just include that as part of my access for that left lateral neck dissection, just to kind of go ahead and open up the parapharyngeal space from the upper part of the neck.
Dr. Orloff.
But the truth is you don't need it.
Dr.
Yeah,
Orloff, what's your routine?
I prefer to do the lateral necks first. I don't think there's a right or wrong way, but my thinking is that I leave the parathyroids and the laryngeal nerves less exposed for less period of time, or I have less period of time for a patient to develop hypocalcemia. I know that there's the argument that you're more tired at the end of the case, and maybe your attention to the detail in the central neck is more fresh and optimized early in the case, but I find also the access to the thyroid is perhaps enhanced by having dissected the lateral neck first. And that includes the retropharyngeal space if I can get to it. And if I can't get to it, if it's just too high, too close to the skull base, I think there is the option of doing it as a separate procedure through a transoral robotic approach or even a mandibular osteotomy approach. But I do as much as I can with the lateral neck. So, and I think maybe that was your point about the cross-sectional imaging, which should be a point that we highlight here, because when there is so much bulky adenopathy, I think that we really need to remember that the retropharynx as well as the retrosternal and mediastinal areas are going to be the hardest, or the areas that you miss with ultrasound. So I do routinely get cross-sectional imaging when I have a patient with, as Russ said, adenopathy that extends to the limits of my view, especially, concern about the presence of retropharyngeal disease that I wouldn't see otherwise.
So this patient comes to your office when you see that much of a disease in the low neck. Do you also get a chest CT?
Yeah, I mean, in my office or practice, we call it a thyroid CT, which includes the skull base to the aortic arch. It's a mediastinal CT. It's not necessarily a pulmonary CT, but often, in collaboration with whomever is my referring physician, there will be a neck and chest CT done. So one way or the other, it gets covered.
Okay. And how did you do this case? Did you do the thyroid first? Did you do the neck first? What's your routine?
Yeah, I always do the lateral neck first. Like Lisa said, I think the exposure that you get in the total thyroid is so much better when you do the lateral neck compartments first. And if you're worried about, can I find the nerve, you can always go and stimulate the vagus very easily. So that's just how I've done it. I mean, I get all the other reasons to do it the other way, but I did both lateral neck dissections and the retropharyngeal node dissection first, and then the total thyroid.
Yeah.
Okay.
I didn't know if you were going to go there with this, going back to the original presentation of the patient with Graves' disease. And I have the privilege of working right now with the ATA on revising the ATA guidelines for thyroid nodules. And one of the questions that we're asking is whether patients who are diagnosed with Graves' disease should routinely have thyroid imaging. And we're finding that there's a paucity of evidence, like so many questions that we have in thyroidology, that you think, what you've been taught is sort of, gospel, but there's a lot of sort of good practice statements and retrospective, limited quality studies, but there's not great evidence. And we are trying to come to a determination of, my personal feeling is that somebody with Graves' disease, there is evidence for there being an increased risk of thyroid cancer in Graves' disease. So also patients with Graves' disease do tend to have enlarged thyroids. And I think that our ability to detect abnormalities just by manual palpation is limited. So I think it's very low risk and low cost to get an ultrasound in somebody with newly diagnosed Graves.
Okay.
This patient happened to, it sounds like she had Graves' disease for quite a few years before she presented with the, the nodular disease.
Yeah.
So perhaps this might have been caught at an earlier stage. I don't know if it would have made a difference, but.
And Dan, how scarred was the thyroid when you, with Graves, they can be pretty sticky and pretty bloody. How bad was the thyroid when you took it out?
Well, I don't remember, so it must not have been too bad. No, I don't think it was too bad, actually.
Okay. All right. Do you have another slide?
I think I have one more, just the follow-up slide. She had low PTH, but that subsequently we were able to get her off of calcium. Interestingly, she had a thyrogen stimulated iodine scan 4 months post-op and had just a small amount of uptake in the thyroid bed with no uptake elsewhere, and so her endocrinologist elected not to give her radioactive iodine.
Wow.
And she's now 7 months post-op with a TG of 0.7.
Great. So this is
Nice
fantastic.
work.
Yes, and unfortunately we're running out of time, but this is a perfect case to show that surgery done well, do we really need REI even when they have bulky disease such as this? Just very quick, Dr. Orloff, when do you do radioactive iodine nowadays?
I think the very simple statement is when I am concerned about extra nodal disease, basically invasive disease into the soft tissue. I don't think it works well inside nodes if nodes have intact capsules, and like Dan showed, you can get clearance. So yeah, that's a simple
All right,
simple
very good.
answer.
And we all agree that if the patient comes in with stimulated thyroglobulin is negative, we shouldn't be doing RAI. I think almost no, unless there is another very overwhelming reason. Fantastic, great job, Dan. That was amazing.
Yeah,
Thank you
nice
so
job.
much.
Wow.
So I think we learned quite a few things here. Let's just start with the next case, Dr. Ashley May. Is it Ashley or is it Alan next? All right.
Ashley.
Okay.
You're muted, Ashley.
Got it. Okay, sorry about that. Okay, so I present the next case. So this is a case of a 56-year-old female who presented with a 3 to 4 month history of dysphagia, lump in the throat sensation, and a palpable low right neck mass. Prior medical history, only of some lung disease and some hypertension, no prior head and neck surgery, some social tobacco, no thyroid cancer history in the family that she knows of, but she was adopted and she believes her mother may have had an abdominal tumor of some sort, and medicines as listed below. So of course you do a comprehensive head and neck exam with important findings noted in bold. She does have a mild, somewhat breathy dysphonia. Along her neck, she has some asymmetry along the right lower neck in the thyroid region and a palpable lower neck lymph node that seems to be focal without other palpable lateral neck nodes. On your flexible scope exam, she does have a right cord paresis.
Okay. Let me ask Alan. Alan, so this patient comes to you already, nerve is gone. The neck is kind of looking, kind of that have that ominous fullness down there. So how would you approach these guys? What's your routine?
Bob, I don't even know the full story yet. Come on.
That's all you get today.
That's all I get. If someone's got a right cord paresis and we're presuming it's a thyroid mass, I'd be somewhat concerned that this is a more aggressive phenotype, aggressive histology. It sounds like there's no family history, there's no genetic or hereditary concerns, but I would take a good hard look at the ultrasound. As we discussed in the first case, most likely pursue some cross-sectional imaging to better characterize this.
Okay, very good.
Ashley, could you just Ashley, could you just clarify? Is that vocal cord paresis where there's some movement visualized, or it's paralyzed?
Correct. Paresis. Yeah. So some movement, but certainly asymmetric.
Okay. All right.
So as stated, the patient underwent the appropriate workup. We began with a thyroid ultrasound, and based on the palpable lateral neck node, also underwent a contrasted neck scan. In line with that, also underwent a biopsy of what appeared upon her thyroid ultrasound.
Okay. Now, Dr. Smith, this one looks like it's aggressive thyroid cancer or something. And if you get a diagnosis of thyroid cancer, do you send these for genetic testing or you don't?
At this point, the needle biopsy is still going to guide where we're going to initially be with this. I think the role of upfront genetic testing becomes more critical if there's a concern that this is a very poorly differentiated thyroid cancer, or whether we get into the category of anaplastic cancer, which I think we're going to talk about potentially later. But if this looks still like from a biopsy that it's going to be a papillary or even a medullary, I don't know that the upfront genetic testing of the biopsy really makes that big of an impact upon the overall treatment plan.
Okay. What if they say it's some sort of poorly differentiated cancer, but we don't know what it is, which pathologists sometimes love to say that.
So I think in that scenario, it does start to bring in the concern that is this someone who is operable? And so then I think we're being able to review the imaging to see if this is a patient who's going to be able to have a complete resection without a laryngectomy or other more advanced procedure becomes an important distinction from a perspective of whether or not you're going to consider an upfront operation. Okay. So I think we're really getting into the realm of these being the more anaplastic cancers where the genetic testing starts to play a bigger role.
Okay. What did your ultrasound and CT and FNA show, Ashley?
Okay. So just because this is the next slide, I'll cut to the axial cut scan here. So you can see a right-sided predominant thyroid mass, kind of multilobulated, and you'll notice a right-sided lateral neck node as well. Again, just another cut showing the kind of contour of this going laterally as well. And again, that lateral same neck node. You'll appreciate here why she might have a paresis of her cord. You can see this mass kind of hugging that tracheal wall there. Certainly, causing some compression.
And the biopsy?
Yes, so biopsy revealed a medullary thyroid cancer. And as discussed, was sent for genetic testing, in particular, in this case, of course, looking for RET mutation.
Yeah. So I think the guideline also mentioned that for all medullary thyroid carcinomas, they need to go genetic testing. Dr. Orloff, what's your routine for these kind of cases?
Yeah, I think because different tests take different timelines to get results, we'll often do several things simultaneously. But I think you would typically order some basic labs, such as once you knew it was medullary carcinoma, I would get a calcitonin and CEA level. I would also simultaneously get thyroid function and calcium levels, just to know what their baseline was, and that might give me an indication of whether there's concomitant to parathyroid disease. Urine catecholamines as well, but also ordering the RET mutation analysis, which takes longer to obtain the results. There are instances where if disease is very advanced or the calcitonin comes back very high, that there may be a cause for body imaging, which could also reveal whether there's an adrenal mass. So it kind of depends on what the initial results are.
Yeah. Do you have a threshold for, let's say, calcitonin before you order a PET or body imaging? Ballpark.
I don't think there's a specific number. It depends on the extent of lymphadenopathy in the neck. I think you can have a very high calcitonin level with regional disease alone. But your decision about doing surgery like Russ described, if you're contemplating something more advanced, such as tracheal or laryngeal resection, I think you want to know whether there's disease that you're going to cure distally, and that'll influence perhaps your decision on your local procedure. So I don't have an absolute number for cutoff, but I think that based on the extent of local disease, I would just say a fairly low threshold for body imaging.
Got it. Okay.
So, Babak, I think it's important, though, that we make sure that this is patient germline testing and not tumor-specific testing.
Exactly.
For the genetics.
Yeah.
I think because all these are going to have somatic mutations for RET of the tumor itself. And so the real importance is the germline mutations that look for kind of associations with genetic transference of disease to offspring and to other family members.
Yeah, absolutely. Great point. So Dr. Smith, next question for you. The workup is done. You did see the CT scan. We do have a diagnosis. Do you need any more tests before offering surgery?
So kind of back to the calcitonin level, kind of somewhat arbitrary, but there's pretty good literature to suggest that when patients start having calcitonins in the greater than 10,000 range, that their risk of distant disease at the time of presentation is real. And I think understanding that's important because it could gauge your aggressiveness of your local surgery. So I'm not for sure if we have a calcitonin level, but if the calcitonin level on this patient's 2 to 3 to 4,000, which is something I typically would see with this type of presentation, and the patient had no other systemic symptoms or other findings to make me worried about systemic disease, I would be comfortable of getting ready to take this patient to the OR. And I'm assuming that all the other, the FEO workup was negative.
It was, yes.
All right. I see also Dr. Stack on the call. Dr. Stack, are you free to make a comment? muted. All right, let's move on.
Do you mind if I ask a question since we have so
Yeah,
many
by all
people?
means.
Yeah, we don't see these very commonly, for those of us that don't have other parts of our practice as well. So do you order the urine catecholamine testing in line at the same impulse as you would the calcitonin and the calcium PTH thyroid hormone, or do you wait until you get those results? I always wonder, like, the timeline, you're always waiting on something. Like, do you go ahead and just order it and then wait on those studies to go ahead and order the abdominal imaging, or how do you prioritize?
Okay, Dr. Orloff.
I typically order the urine tests first because they're cheaper, the results come back faster. And the abdominal imaging that you may or may not get, it could miss a very small lesion, but it also, like, depending on sort of how the picture unfolds, you may want the abdominal imaging, even if there are normal catecholamines, to look for liver metastases, for example. So I think that just starting out with getting that information helps guide further decisions about the workup.
And we also nowadays have serum actually catecholamines that you can do, and that's even faster. If you have that,
Yeah.
it might be more expensive than instead of the 24-hour urine. Okay. What about Dr. Let me ask Alan. Alan, once you see medullary, do you just carpet bombing all the tests and be done with it, or you go step by step?
I actually will get the RET mutation first without anything else. I actually think that if it's negative, it obviates getting any of the other testing. I agree that it does take a little bit longer to obtain, but as the endocrinologists we work with tend to use the RET as kind of the gatekeeper mutation, because if it's negative, then many of these tests would not be necessary, right? The abdominal CT imaging. But you're right, the other tests are quick. And they, for an anxious patient, I would not object to getting.
Sure, perfect.
I think one problem is that hypertension is very common, and it's just assumed that everybody has essential hypertension. And, I think that is the dreaded, you don't want to miss a Theo. So I feel like that's, a low threshold if you don't have results as soon as you might need them to make a plan it influences my
Very
plan.
true. Very true.
And I think most centers like these patients to go through the genetic program, which is the hardest appointment to get in the cancer center.
That's true.
This is real world.
Yeah, Russ, do you do serum catecholamine? Do you do urine?
I just do the serum levels. Patients hate collecting urine for 24 hours. It's inconsistent whether they'll even do it. You can send them downstairs and get the blood drawn, and then if there's no significant abnormalities, I think it expedites care.
Okay, all right, Ashley.
All right, very good. So this patient was taken to the OR.
Okay, one second.
Oh, I'm sorry.
So we all agree, surgical disease. Again, how would you do the surgery? What are some pointers? Can you go back to the CT scan?
Sure.
So let me ask Dr. Smith, how would you start this case? How would you go about this case?
So I think, the big critical factor of this case, I think the trachea looks pretty clean on the CT scan, so I'm not worried about tracheal invasion. What's going on with the recurrent nerve, I think, is the biggest issue in regards to kind of nuances. On this patient, I would start very, very low and try to find the nerve down very low in the central neck where I expect it to not be affected with disease, and then would dissect it from very low up towards the larynx to try to figure out the status of the nerve. And in this case, if the nerve easily dissects out of the tumor, I would go ahead and preserve that nerve since there is some function still present. It doesn't sound like the pre-op evaluation suggested it was a complete paralysis. In general, if you have someone with a known malignancy and there's a complete paralysis prior to surgery, the chance of saving that nerve is, in my mind, almost zero. In this case, I think there may be an ability to save a nerve in a meaningful way. And so that, I think, is the one nuance to this surgery, is to make sure you try to find that nerve way low in the central neck. And so then you can dissect it up into the tumor to see whether it's something that you can preserve or not.
Perfect. And then you do the right side, and then do you go to the left side before you go to the neck, or you do the right side, right neck, and then say, maybe I'll do the left now?
So I tend to do the entire central neck component of the operation as the first stage.
Okay. And then if you take the nerve out on the right side, the nerve is gone.
Right.
Any, how would you go? Do you go to the left side or say, maybe I'll come back another day?
So I think the issue of this nuance is if you've sacrificed the nerve, you're not staging the second side with the hope of letting the first side recover before you put the second nerve at risk. And so unfortunately, this is one where you have to just bite the bullet and realize that you have to be extremely meticulous with handling the nerve on that left side after you've already sacrificed the nerve on the right. But this patient needs to have a total thyroidectomy for their medullary cancer. There's no consideration that a lobectomy alone would be adequate therapy. And I think you're best served by doing it with one single operation.
Excellent point. Okay. Dr. Orloff, how would you manage this case in your practice?
Yeah, no, I agree. I agree with Russ. I think my slight difference is that I would perhaps have a lower threshold for sacrificing the nerve up front because there is no radioactive iodine to deal with this afterwards. There is no, this is not that much of a radiosensitive tumor. You can use radiation external beam, but it's not as effective. And I would really prioritize clearance of disease if I could. So I think I would have a lower threshold for medullary than for papillary to sacrifice the nerve. I think one thing that I see in both medullary and papillary is that it's often the metastatic disease in the central neck that it takes out the nerve rather than the primary tumor. Sometimes it's right at the ligament of Berry, but sometimes it's down in the central compartment. So I guess I would, having been there many times where I spent a lot of time dissecting the nerve out only to sacrifice it at the very end, I may be a little bit sooner to be willing to sacrifice it rather than do all that work only to have it have to go.
We're running out of time a little bit.
Is there anybody using automatic periodic stimulation of the vagus nerve as an adjunct for nerve preservation? Been reported by Randolph and Ralph Tufano. They put like on the vagus. They put a stimulator on the vagus nerve and then have periodic stimulation for the duration of the case to help reduce the risk of traction and neuropraxic related injuries to the nerve during the dissection.
To the involved side or the opposite side?
Either or. You could use the involved side to help you with the dissection to try to keep it functional, and or if you have a single functioning nerve, you would place it on the single functioning nerve to minimize the risk of praxic injuries.
Oh, just to like kind of remind you every few minutes that, hey, there's a nerve here?
Yeah, I think that technique has promise, but is not really practical in most instances. I wish it were more so, but you kind of know what you're up against and you can't avoid some retraction, and you already have a nerve that's hurting. And so I think people criticize nerve monitoring in the first place for being kind of noisy, and that adds another element of distraction that may be a little bit counterproductive, but it has promise.
Sorry. All right, we got to finish this case. Ashley?
Okay, very good. So as mentioned, patient underwent a total thyroidectomy, central neck and right lateral neck dissection. His final pathology revealed a 4 centimeter right thyroid, medullary thyroid, and 2 of 36 lymph nodes were positive. His stage as written, and he was RET positive. So
was the nerve involved when you took it out? What happened?
Able to peel it off very slowly. So no, not involved. I think much more just compression just due to bulk, and patient ultimately recovered to some degree.
Okay, perfect. And it's RET positive. So nowadays we do have the RET inhibitors that are approved by FDA.
Right.
Dr. Orloff, have you started immunotherapy in these patients yet?
Sorry, I was looking at the chat. I don't have experience with immunotherapy for these patients. I have experience with tyrosine kinase inhibitor therapy for patients with medullary carcinoma with systemic disease, and systemic therapy is effective, but I don't have experience with immunotherapy.
Okay.
So Ashley, is this a germline mutation positive patient, or is this just a somatic positive mutation of the tumor itself?
This was germline.
Okay, so that gets into the bigger issues of when to talk to the family, siblings, children in regards
She was
to
adopted, right?
screening.
Yeah.
All right.
Yeah.
Okay. Fantastic case. Oh, was there any tracheal involvement, or were you able to take this off of the trachea?
No, it was able to be peeled off. It just kind of contoured into the.
All right, perfect. I don't have the time to ask about how you manage trachea. Let's just start with Dr. Ho's case, and then maybe we ask about trachea in the first one. Okay, thank you so much. Great case.
Nice work.
Yes. All right, Alan. So for those of you who don't know, Alan does like 200 thyroid a week on a good day and a good week, and a not busy week. Okay.
You're muted, Alan.
All right, great. Thanks, Babak. All right, this is a 85-year-old Taiwanese male with a low-grade stridor hemoptysis. It started in June with intermittent cough and coughing up with blood. His pulmonologist, his internist couldn't really figure it out at first, but eventually progressed to stridor. He was known to have right thyroid fullness and induration, but otherwise is a pretty asymptomatic and healthy guy. And he underwent an FNA of the thyroid mass, and here's a sneak peek at the imaging. So otherwise healthy, no prior surgery, no family history of thyroid cancer. He's not on thyroid medication.
Okay, well, let's see. Dr. Rocky, so you look at the CT scan and there's actually zero iodine uptake in the contrast. So you know what you're dealing with. How do you approach these? What's your routine at Duke?
Sorry, you have to forgive me. I'm dealing with some call issues here, but I may not have heard all of that. But you said that he had an FNA. What was the result of the FNA?
Okay, what's the result of the FNA?
Oh, we're gonna do the reveal now? Okay.
No, we're not gonna do the reveal now. Okay, so what would you get? You're right, I love it. So the FNA is like, something's ugly, but we don't know. What would you do?
I think, a PET scan is not a bad idea in this situation. I mean, I think it all depends on what you find on the FNA, though. I mean, I think we kind of know what we're dealing with here, and it's something bad, something poorly differentiated, probably. But
how much do you trust an FNA that says, poorly differentiated cancer, but they don't call it thyroid cancer? What would you do in that case?
Yeah, I mean, we typically get a core if we can't sort it out from that.
Yeah, I think that's the critical point here, that because that has happened to me at least a couple of times. I'm happy to share that, but I think Dan is absolutely right that do not go that route. If they say, it's poorly differentiated, and oh, well, I mean, it's thyroid, it could be thyroid. Dr. Orloff, when do you ask for a core?
Oftentimes, if this is a poorly differentiated or anaplastic cancer, you'll get necrosis on your FNA and inflammatory cells, macrophages and whatnot, and you really won't have much epithelium. And so getting a core can get around that issue, but also just give more tissue for doing genetic testing. And you've been alluding to genetic testing earlier in the evening, but the core biopsy gives you more material for immunohistochemistry, not just immunocytochemistry. So,
Dr. Smith, when do you get core?
Yeah, I think just to go back though, this presentation is the real critical part of this case. As we take the history on most patients with thyroid cancer, it's this very innocent, long-standing, asymptomatic. This is a guy who was coughing up a little bit of blood, and the next month he has stridor within a few weeks. And so this really kind of puts you into that anaplastic cancer category, regardless of what the biopsy is, in my mind. I think you have to start thinking anaplastic from the front, and, core versus fine needle versus an open biopsy to whatever extent you need to get the tissue. I mean, this truly is presenting in the way that anaplastic cancer presents. And I think it needs to be managed that way, even if your biopsy suggests that this is just a poorly differentiated cancer. This is not, I mean, in my experience, even the more aggressive, poorly differentiated cancers are tumors that have progressed over a period of 4 to 6 months and not 4 weeks.
All right. Well, if I know Dr. Ho, I think this case gonna end up being lymphoma, but let's see what Alan did.
So here's very funny, Bob. There'll be some curveballs I'll show you. But anyway, his stridor was intermittent. So at first, here's his scope exam, and actually his cords are fine. But you can see something just beyond the surface in the subglottic or even beyond into the tracheal area. And this is where I think fiber optic laryngoscopy is very interesting. So you have a guy who's coughing up blood and intermittent stridor, but actually his cords are actually okay. And actually, and the stridor is probably more subglottic as opposed to glottic. Okay. Here's actually his scan. Just there's a video of it because I think it tells a bit more dynamically. You can see the cords there, and then there's the tumor with this possible tracheal erosion or invasion. And then here is the sagittal, or sorry, coronal view showing some tracheal deviation, and also again potentially some tracheal invasion in this area. And then here's the CT chest, which was obtained. And you can start to see, I guess I'll just skip ahead, but you can see there are some interesting findings in both sides of the lung, including that big thing there on the left side, showing that more or less there are some lung nodules. So here's one right here. I think the cursor will tell you right there's a big spiculated lesion, and then another small lesion on the right side. And then one more lung nodule, I think, right there on the lower left lung. And so here are screenshots of it. And here's the CT neck and chest report showing a mass. They call it the supraglottic fossa, but it's really the thyroid invading the right lateral aspect of the trachea. And then some lung nodules that they would say are consistent with pulmonary metastasis. And here's the FNA. It was a high-grade carcinoma with squamous features. Our pathologists, they like the word squamous, and the interpretation is more or less that it's most consistent with anaplastic thyroid carcinoma. And here at Babak, I know you're really into molecular testing, but unfortunately, this is where we really struck out. The main thing is that it was a BRAF negative anaplastic thyroid cancer. Sometimes we send for rapid next-gen sequencing, but it's V600E that's the most important for BRAF MEK inhibition. And it doesn't matter if they're BRAF positive for other things. If it's BRAF negative for V600E, then they don't qualify for the systemic therapy options that are newly available.
Okay, question for you, Alan. Is this profile consistent with thyroid at all?
Oh yeah, this is a memorial PIMP question. I can tell you're thinking of me, Bob. So TTF is actually a lung marker, a lung cancer marker. It's a misnomer. So thyroid transcription factor being negative is actually consistent with a thyroid carcinoma. PAX8 is actually more of a thyroid marker. So the fact that it's positive suggests that it is thyroid in origin. However, when it's anaplastic, all things kind of go out the window because it's a dedifferentiated variant. That may be why thyroglobulin is negative. And if these were negative, we still would consider it an anaplastic.
Perfect. Thank you so much for that. I mean, you know what? I would never even dare to pimp you on thyroid. Okay, let's get that out of there. Okay, so Dr. Smith.
Oh, sorry.
We have a genetic testing. We have the FNA. Looks like anaplastic, acts like anaplastic. What's your institution routine?
So beyond BRAF, PD-L1 is kind of the big other kind of target that we want to look for. And if this patient has a very high PD-L1 mutational status, then I think immunotherapy would be something to be considered. This patient unfortunately has a very rapid demise in their future. And so I think having very frank discussions with both he and his family when he's at the age of 85 of what their wishes are, given that he has a diagnosis that has a very grim prognosis, about whether they want to be aggressive with therapy, because I do think that we can be aggressive with therapy in these patients in regards to considering cytotoxic chemotherapy. You can consider radiation therapy. Immunotherapy is also going to be other consideration. There will be some other genetic testing that may bring some other targeted agents into the discussion. But this patient obviously has stage 4C disease. This is not typically going to be considered curable disease. And I think really having end-of-life discussions with the patient in regards to tracheostomy, feeding tube, and the nature of how they want this managed is really critical to take the best care of the patient in this situation.
Okay, Dr. Orloff, what's the stand?
I think that's beautifully said. I mean, Russ described it well, and it's that just really heartbreaking moment when you get the BRAF results back, basically, because you're hoping against hope that this is going to be BRAF positive, and the patient may be able to benefit from targeted therapy with dabrafenib and trametinib, which has been shown to, if not be useful in the neoadjuvant setting, which it can be, but even as a palliative regimen, if that's not an option, the other therapies, often the toxicity outweighs the benefit, and I think Russ is spot on.
Do you guys do a trial of induction chemo immuno before considering any others, or do you just go the palliative chemo RT route?
If you're asking with BRAF positivity, we approach it with the possibility that this is going to be induction
Sure.
or neoadjuvant. But basically, if it's BRAF negative, we don't get ours or the patient's hopes up that that's going to be an option.
Okay. Alan?
So for us, this is we are surgeons, so there has to be some kind of surgical caveat to this. He was starting to become more and more to suffer airway distress. He had been in the hospital for a week, and we could see him start to decompensate. He didn't want a trach. He wanted quality of life, and he didn't want a trach. He didn't want a lot of things. He didn't want radiation. He didn't want toxic chemotherapy. And he had lung mets, so we had a goals of care discussion, a supportive care consult. And I think his life expectancy was in the order of months, but they wanted something so that he could at least get his airway back for some time. Incidentally, he also didn't want anything radical like a tracheal resection. So we decided to do a palliative decompressive thyroidectomy to alleviate the stridor and the hemoptysis. So intraoperatively, we noted, unfortunately, invasion of the right trachea and also invasion of the right recurrent laryngeal nerve, even though it was working at the time. And then, of course, during dissection, the nerve loss signal. Here's a picture after we were able to remove the tumor, at least the first half of it. So you can see the left thyroid is still intact. This is all just desmoplastic infiltration from the strap muscles. And of course, that's the ET2 peeking through the blue. So there's about a quarter-sized tracheal defect. You have one nerve out. And a patient who refused to do any sort of tracheal resection.
And it's probably Friday the 13th too.
Right.
Okay, Dr. Orloff, you are just going about your merry way, and your junior colleague calls you, say, can you come take a look at this?
Yeah, I think this is where our enthusiasm for these wanes, as we have been through these experiences before, but knowing that there's going to be still microscopic positive disease, the wound healing in this area is not going to be good. And so whether you try to close that primarily, which is not going to be easy, whether you bring a muscle flap in there, I don't think you are really in a position to bring any free tissue in. I would attempt to bring some sort of vascularized muscle to cover that tracheal defect. I mean, the alternative, because he said he didn't want a tracheotomy, because you could make that into a tracheotomy, which would have been probably the best option. I think it's, whether you had expected the nerve to go out or not, that was appropriate to plan just a lobectomy and not compromise the nerve and the parathyroids on the other side. So you have that going for you, but it's just the healing in this area is going to be difficult no matter what. I would drain the neck, whatever else I do. And I don't know, my optimism is kind of low for it healing. So I'm eager to hear what Alan
Dr. Smith, it is Florida, So what's going on? What can we do?
This is a tough situation, Alan. I wouldn't envy this. I personally probably would have tried to avoid getting into this situation because I don't see that this is going to be a manageable scenario. Once, I mean, if I ever do contemplate operating on these, once I get to the point where I've lost my tissue plane and I don't have a clue of where I am, I typically stop, because the problem is that now, if you wanted to consider any systemic therapy, you're going to have a wound healing issue that's going to be a compromise. I think in this case, as much as they wanted to avoid a tracheostomy, I would create this into a small tracheal fistula to the skin. I think that's the safest way to manage this wound, because otherwise you're going to just be leaking secretions into the neck and probably end up into an infectious process.
Okay,
I think,
great. Well, I would say I would commend Alan for listening to the patient and undertaking one of the most difficult things they can ever do. And I commend you. I mean, it's not an easy, and we all know it, but I really appreciate that you are willing to go to this route, this far for your patients, and really considering their wishes and their will. Okay, tell us what happened next.
So I think we decided to stop at the hemithyroid, just given the loss of signal. There was no point. There's no point in doing a total thyroid. And then we decided to patch it with an SCM rotation flap. There was some concern about secretions, et cetera, as Russ said. But this is what it looked like after we put in the SCM rotation flap. We just rotate some tissue from the right sternocleidomastoid muscle, cleaned up the edges as best we could, and then just sutured this down with some horizontal mattress sutures. And we were able to extubate him without too much trouble. This is the final pathology showing a 6-centimeter anaplastic thyroid cancer, et cetera, et cetera. And for all you doubters out there, I actually think it's actually a good option when you're in a pinch. Of course, this is post-ops vocal cord exam showing right vocal cord paralysis. But his stridor resolved. He was hoarse, but he was able to compensate with no aspiration events. He was tolerating a regular diet, and we discharged him after 3 days without a tracheostomy. So the clinical course afterwards was he saw radiation oncology, declined adjuvant chemoradiation because he wanted to maintain his quality of life. We considered a clinical trial that MD Anderson's running on BRAF negative anaplastic with lenvatinib and immunotherapy, but he declined. He didn't think that they were going to offer him much. And lenvatinib does have its fair share of toxicities, especially for an 85-year-old. His tumor mutation burden and PDL status was low or negative, so we didn't really think immunotherapy was going to help. And ultimately he was placed on hospice, but he died with some dignity. He died from distant disease rather than local disease.
Fantastic. Well, first of all, thank you so much for sharing this with the group. I think these are rare, and this is very, very helpful to all of us because we all going to see this. And I really, again, commend you for undertaking this very difficult situation and really managing the best anybody could do. All right, we're running out of time. Two last comments. Dr. Orloff.
Yeah, Alan, really nice work and nice presentation. I would just add to that there's the consideration for involving our interventional pulmonology colleagues when there is tracheal involvement and you don't want to do an open procedure. Sometimes you can do a debulking, laser endoscopic procedure or stenting. So that's just something to remember in this scenario that also helps with the airway symptoms. But that's a really nice outcome for this guy under the circumstances.
Thank you. Dr. Smith?
Yeah, I think that, listening to the patients are very critical. And it sounds like he wanted you to try something, and I applaud you for giving him an opportunity to have a different outcome.
All right, very good. It's 8:02. Thank you, everybody. I'm really sorry if I couldn't ask more people to comment. Fantastic session as always. We're gonna see you again in December for our skin cancer. I hope you can all join us. This is it for tonight. Thank you again for Dr. Daniel Rocky, Dr. Alan Ho, Dr. Ashley Mays, and our panel, Dr. Lisa Orloff and Dr. Russ Smith.
Thank you all. Thank you, everybody.
Everyone.
Thanks, Bob, for
Appreciate
your
it.
presentation.